Well, thank you, Amanda. It's great to be with you all today. I will preface this by saying that we got about 7 or 8 inches of snow in Nashville, and so I do have kids running around the house, and so you might hear them from time to time, and so that's just the nature of living in Nashville. When it snows, everything shuts down. But it's good to be here today. Thankful for the opportunity to talk to you all about antipsychotics in the long-term care setting. What I'm hoping to accomplish with this talk is to just kind of help us to really understand what we're trying to do. I think a lot of times we get focused in on we've got to stop antipsychotic use or or psychotropic use in our facility, and we just get kind of bogged down in the rules about that. And so I want to spend some time just talking about what these antipsychotics are, when they could be helpful, when they're not helpful, and then how we can think about what those strategies are for getting them off. If you want to go to the next slide. So we're going to distinguish between how we use medications with a focus on this idea of on-label versus off-label uses. And we're going to apply that understanding to the use of antipsychotics because they are a class of medications that have a really big mix of on-label and off-label use. We'll talk about the medications themselves and some of their uses in practice. We'll talk about the role of antipsychotics in the long-term care setting and how they can be both beneficial but also potentially harmful to your patients. We'll talk about some of the risks associated with them. And then we're going to talk a little bit about gradual dose reduction and how we use gradual dose reduction to manage psychotropics. I want you to think about gradual dose reduction as not something to just write on a sheet of paper to send to your physician or to send to your psych nurse practitioner, but as this way for us to use a strategy for information gathering about how the antipsychotic and the patient are interacting. And so while we think about gradual dose reduction as always a way for us, a means to an end to get this drug off of this patient's list and therefore make me more compliant, sometimes gradual dose reduction can help us determine other pieces of information, like the patient doesn't need to be off the medication. Maybe the patient needs to be on a lower dose. Maybe the patient needs to be on a higher dose. So I want us to think about a little bit more deeply what this gradual dose reduction strategy looks like and how we use it to get information about how antipsychotics are helpful or harmful in our patients. Next slide. So it's important to note that antipsychotic medications are indicated for psychosis. Psychosis is a symptom of mental illness characterized by a distorted sense of reality. They're commonly used in practice, and it's important to note that when we think about label, on-label, and off-label use, we're talking about this idea of FDA-approved indications. And so the main FDA-approved indications for antipsychotic use are schizophrenia and schizoaffective disorders, bipolar disorders, agitation, but mostly acute agitation, and they are approved by the FDA. Some of the medications are approved by the FDA for major depressive disorders. They are also used off-label, and typically that happens in the inpatient setting, and that's where it interacts with our long-term care and nursing home facilities, is that patients get them in the inpatient setting for acute management, off-label management, but then they're continued on MedRex and so forth. There are associated risks and benefits to antipsychotics, and we have to kind of think about them, providers and caregivers, in all settings, not just in long-term care, the kind of the focus of this presentation, but we also want to encourage providers and caregivers in the inpatient setting and the community setting to be thoughtful about how these medications are used. So big picture, antipsychotics are approved for specific psychosis-related conditions. It is not uncommon for medications to be used outside of those FDA-approved labeled indications, and this medication class is no different. Next slide. When we think about this idea of on-label versus off-label uses, the label refers to the FDA-approved package insert. So without getting into too much detail, the life cycle of a medication is It goes through preclinical, so animal studies. It goes into human studies. Typically, that starts with healthy individuals. It then goes into individuals with a particular targeted disease state. It goes to a large scale study. And then that information is all gathered and sent to the FDA, and the FDA makes an approval decision. If that medication is approved, that medication is approved based on a specific indication. So the FDA carefully evaluates the benefits and risks of the specific use of the medication. So when Seroquel or quetiapine went for FDA approval, they studied it in patients with bipolar. They studied it in patients with schizophrenia and schizoaffective disorders, sent that information to the FDA. The FDA then said, let me look at the benefits and risks of using Seroquel in this patient population, in this disease state of interest. And then the FDA approved that and said that it was safe and effective, created a package insert labeling, and the medication was able to be marketed for that particular indication. Now, the pharmaceutical company could then go back and say, okay, we studied it in schizoaffective disorder. Now we want to study it in bipolar, or now we want to study it in acute agitation. They would have to go then through that process. It's an abbreviated process, but that could add additional indications on. And so when you get to thinking about on-label indications, these are indications where the FDA has said, here's a disease state, here's a drug. Is this safe and effective? Does this meet our criteria for safe and effective? If yes, it's on label. And if not, either the FDA has not approved it, which is the most commonly the case, or the FDA can say, no, this can't actually be used for this particular indication. When we think about off-label, we're really talking about a situation where a medication is used for an indication that hasn't been approved by the FDA. And almost exclusively, this is a situation where the FDA hasn't actually evaluated it. So it's not that the FDA is saying, okay, you tried to use Seroquel in insomnia and we found that it was actually more harmful than beneficial. So we're saying, no, you're not approved. That is not what's happening with off-label. This is a situation where practitioners, providers, over the course of time are using a medication on an indication that hasn't been evaluated by the FDA and therefore hasn't been approved. So I don't want you to think that this is a situation where the FDA is saying, don't use this, but we are. It's a situation where the FDA hasn't weighed in either way, and we're using it because the provider judges that there's a medical appropriate use. This is a lot more subjective. It's much more patient specific. We do have information and we end up doing studies that are not, big funded, large studies that show benefit and harm and so forth, but we don't have as much data as we would for an on-label use. So there are a lot of situations where medications are used off-label. We'll get into that, but I just wanted to make that clarification, because when we think about appropriateness of antipsychotic use, we're often trying to apply this on-label use to what we're dealing with. Next slide. So here's some off-label examples. The medication is given in a different form than that which the FDA has approved. So the FDA approves maybe an oral tablet, and there's some kind of a transdermal application that is used. Medication is given at a different dosing than that which is the FDA approved. So we're treating schizophrenia. The FDA kind of evaluated up to 200 milligrams, for example, and we're going to use 300 milligrams. So that would be an off-label. There are some medications still that predate the FDA approval process. That happened with the Kefauver-Harris Act, I think, in the 1960s. And there are some medications that are older than 1960 that have been used in practice and kind of just adopted and haven't gone through FDA approval processes. And then there are medications that are in the same class as other medications, and you assume that there's a class effect. And so you use them off. They're technically off-label, but they're FDA approved. So some antipsychotics, the manufacturer didn't study them in certain types of psychosis-related illnesses, but they're in the same class as other antipsychotics, and therefore they are utilized. We see this very often in antimicrobials. A lot of time antimicrobials are approved for skin and soft tissue infections because it's the easiest thing to study. But then when they get on market, they are applied to other infectious diseases because they kill certain bacteria that could be growing in the particular infection. And then oncology agents are other examples of this. And so there are some times when appropriate use can include off-label use, including antipsychotics. But when we think about the rules and regulations involved with long-term care, we're often trying to limit the use of antipsychotics to those that have an FDA-approved indication. Next slide. So antipsychotic medications are a general class of medications that have activity in patients with various forms of psychosis. They differ from other agents that are used in psychosis treatment. So there are sedatives and mood stabilizers and antidepressants that have benefit in patients with different type of psychosis-related conditions. It's important to note that antipsychotic medications do also have side effects that could look like they are treating a condition. So antipsychotics have sedative effects. And so you might be giving somebody an antipsychotic and seeing a sedative effect that you think is their psychosis being controlled. And so that's an important distinction when we think about these medications, is that we want to distinguish efficacy from the side effects that could look like efficacy but aren't. When we from a pharmacologic perspective, look at antipsychotics, we tend to define them in two generations. We call it first generation and second generation. They also sometimes can be called typical antipsychotics for first generation and atypical antipsychotics for second generation. We'll talk about there are differences between the generations, which is why I bring them up. Next slide. So here's a list of all the different medications. Our first generation or typical antipsychotics include medications like chlorpromazine, and probably the most common one now in practice is haloperidol. These medications are less commonly used in practice. They're often used for acute agitation rather than chronic because of the side effect profile of them in comparison to the atypical or second generation antipsychotics. And then you probably are more familiar with some of these second generation antipsychotics like olanzapine or Zyprexa, quetiapine or Seroquel, and Geodon or Ziprasidone. So there's kind of a list of them. Next slide. So first generation antipsychotics were the first generation. So we're talking about a historical progression of the development of these antipsychotics. They were out first. They're more elderly medications, for lack of a better term, but they are medications that we have historically used and were considered standard of care for management of psychosis disorders. Generally speaking, though, this group of medications, as we often see in the progression of and development of medications, we often see that the older medications have efficacy, but they tend to have a higher side effect profile. I think about anticoagulants, for example. Historically, warfarin was my standard of care anticoagulant, but it's associated with a significantly higher side effect profile, predominantly bleeding, more drug interactions, more food interactions, and so forth than my newer agents like apixaban and rivaroxaban that tend to have a lower bleeding risk and a lower drug interaction, easier to use kind of thing. So we see that in the progression of antipsychotics. We see more cardiac conduction issues, including QT prolongation. It's important to note that in our patient population, in the long-term care setting, we do tend to have more medically complex patients. Sometimes we have more elderly patients, but certainly we have patients that are on medications. And there are a lot of medications out there, not just antipsychotics, that cause QT prolongation. The risk of QT prolongation is arrhythmia, including fatal arrhythmias. And so our patient population in the long-term care setting tends to be at higher risk because of other medications and other disease states. And so when we add on these first-generation antipsychotics, they tend to cause more problems. They also have a higher incidence of what we call extrapyramidal side effects. These are predominantly dyskinesias, involuntary movements, and things like that. Obviously, we have a higher falls risk in our patient population, so adding on these medications is going to increase the risk of falls, as well as the decrease in quality of life and so forth. They have more anticholinergic side effects. Again, this is going to increase falls risk. and they have more sedation and disassociation associated with it. So disassociation is probably one of the mechanisms of efficacy for antipsychotics. It's just that the patient gets more dissociated, so they're more confused than they otherwise would be. Most of the time, these medications are being used for acute symptom control. They're used as adjunctive agents if they can't get controlled on other medications. And they've historically been effective, but we really need to have a good conversation if we're going to use these for chronic use. We're going to have a good risk-benefit conversation. And then we want to be very vigilant about drug interactions with other medications. Next slide. Here's a few of our common ones: chlorpromazine or thorazine. Typically, we're going to give 50 to 150 daily and titrate up to effect. They have these characteristic side effects of sedation, extrapyramidal side effects, and anticholinergic side effects. They also, all antipsychotics cause weight gain and can cause metabolic syndrome. Which, again, these are elderly patients. These are patients that are already medically complex. So they're also at risk for cardiovascular disease and so forth, and diabetes, and this would worsen that risk. Oftentimes, chlorpromazine in this time period is used for hiccups and nausea and vomiting and acute agitation, but rarely for chronic use. Haldol or haloperidol is used in a lot of different settings. It probably is one of the most commonly used chronic medications. So you can give the depot injections. It does still have all those characteristic side effects of first generations. It's more has more sedation and disassociation, especially when you have cumulative dosing. It does have a high risk of cardiac conduction effects, and so those life-threatening arrhythmias. But it is still used in acute agitation and mania and delirium. It's commonly used in the inpatient setting for acute management. So sometimes when you get a patient coming into your facility with a med reconciliation process, you might see Haldol as a PRN medication for acute agitation, and that would be something to try to get stopped before they get into the facility. Next slide. Second generation antipsychotics are going to be the mainstays of therapy for psychosis-related disorders, especially in the patient population that we're discussing today. They are used in acute management as well, and sometimes that leaks into long-term care. But if you're going to use an antipsychotic and you have an appropriate indication, the second generation antipsychotics are going to be more appropriate from a risk-benefit perspective for more chronic use. They have a lower side effect profile. They have less cardiac conduction issues. They have less anticholinergic and dyskinesia side effects. They have less sedation and less apparent confusion associated with them. They do have a little bit of a higher incidence of metabolic effect, which causes weight gain and potentially increases the risk of the development of diabetes. Although there are some within the class that have a lower incidence. These are going to be chronically used for management in stable disease. They do have some off-label uses, especially in the hospital and long-term care setting, that are increasing. And I would argue that some of that is good and some of that is probably not so good. And so the patient that comes into a hospital facility and a patient that is in a long-term care facility are probably in different scenarios. And so letting that leak from inpatient to long-term care of the use of antipsychotics is mostly going to be a problem. Next slide. Here's some examples. I've got a few slides with examples. Abilify or aripiprazole is a very commonly used agent. It tends to have probably the lowest side effect profile across the board of all the general antipsychotics or second generation antipsychotics. Low metabolic effects comparatively, lower incidence of sedation and those extrapyramidal side effects. Clozapine probably is, if I were to put a drug kind of 1 foot in first generation and 1 foot in second generation, it would be clozapine. And typically it's going to be used in patients that have a really close follow-up. It does have what we call a risk evaluation and mitigation strategy, or REMS program. So FDA approved clozapine for use in psychosis and psychosis-related conditions. But clozapine has a really high risk of hematologic side effects. And so FDA said, you can use this, but we have to have this additional program to try to monitor for side effects, and specifically hematologic side effects. So if you have anybody on clozapine, you know that you have to get lab work periodically in order to continue them on it, because it can cause a specific kind of blood disorder. It's not as commonly used because of this, and because it does have a higher side effect profile than other second generation antipsychotics. But there are patients that kind of walk through the use of different antipsychotics and get to where they have no other choice but clozapine. And there are some benefits to using the medication. Next slide. These two are probably the two most common forms of atypical or second generation antipsychotics, olanzapine and quetiapine. They tend to have kind of be middle of the road across the board with side effects. We also see that these are two medications that are often used in the inpatient setting for acute agitation, for delirium, and for insomnia in the inpatient setting. And so they tend to have a little bit more sedation than some of our other agents like ziprasidone and aripiprazole. But these two medications are commonly used, and I won't say that it's always appropriate. It's probably more inappropriate than not for in the inpatient setting, and why you sometimes will see them continued probably accidentally in the long-term care setting. Next slide. Risperidone and ziprasidone are much more commonly used as chronic medications. Risperidone probably has more sedation, or I'm sorry, a little bit less sedation, a little bit less hypotension, and tends to be pretty effective over the course of managing the patient. It does have some metabolic effects, so it increases the risk of weight gain and diabetes. Ziprasidone, again, I put kind of ziprasidone or Geodon and Abilify in the same category in terms of pretty low side effect profile if we're comparing them to the other antipsychotics in this subclass. And so these, if we were to use these and you had a patient, or you had to use antipsychotics and it was a patient that might be at increased risk of falling and sedation and so forth, Abilify and Geodon are going to be probably the best two agents from a side effect profile to consider while maintaining the efficacy that we need from them. Next slide. There are some newer medications that are kind of in and out of use. Safras, Rexulti, Vraylar, and Latuda. They tend to be used as a second or third line, just because they're still brand names, and so they're still on the more expensive side. But they do have some niche use. Vraylar, for example, has a low side effect profile and has a lot of benefit in bipolar disorder, especially bipolar 1. And Latuda also has a low side effect profile as well. Most of the newer agents have also been studied as an adjunct for major depressive disorder. And you guys maybe have even seen commercials on TV talking about using this as an adjunct in addition to antidepressants for major depressive disorder. That has tended to paint all the atypicals as having benefit in major depressive disorder. And so you will sometimes see quetiapine, which doesn't have a ton of evidence in major depressive disorder, being used as a class effect. Well, if Rexulti works for this, then so does anything else in the class, because mechanisms are similar. Next slide. So we've talked about this a little bit already. Antipsychotic use in practice, it's obviously these are agents of choice for those psychosis-related conditions: acute mania, acute agitation, bipolar disorders, schizophrenia, and schizoaffective disorders. These are the agent of choice, and then we are sometimes seeing them as adjunctive agents. Again, we're talking mostly about on-label as a class: major depressive disorders, depression, and some other major neurocognitive disorders. So that's when they should be used in practice. So when you're evaluating a patient and determining if they're a candidate for antipsychotic use, these are the indications that you can say, okay, let's go look for at somebody else because this person needs to be on it. That does not mean that they are on the right dose or they are on the right medication. And so if you're having behaviors in patients that do have these conditions and are on antipsychotics, while we would not be worried about regulations affecting that patient and whether you're in compliance, we do still want to look at them and make sure that their medication and their dosing is optimized. Next slide. There are tons of off-label uses for antipsychotics, and it's very difficult to differentiate their use as from an efficacy perspective. So the drug is actually positively impacting this patient population versus the side effect of the medication. So they all cause sedation to varying levels. And so if you give an antipsychotic to someone with anxiety, it's possible that they may be benefiting from the medication itself, but it's also possible that the sedation and disassociation that is impacting the patient, the side effects of the medication are also affecting it, especially when you think about insomnia. Insomnia is probably not, we're probably giving the antipsychotic for its side effect than anything else. Now, maybe there's some component of the patient's insomnia that is related to decrease in their mind is racing, or they're having like flight of ideas and things like that, and the medication could be helping. But most of the time we're talking about the side effect. Whereas there is data to suggest the use of antipsychotics in Tourette syndrome and personality disorders, which may or may not be classified as a psychosis-related condition. Obsessive compulsive disorder. There are some studies that show benefit, but these can be used in a lot of off-label indications. And it's really important that you're talking to your providers and your caregivers to make sure that what we're using them for is not for their side effects, but actually for a condition, and that there's evidence to support it, even if there's not an FDA labeled indication. Next slide. A little bit of a deep dive on some of this because this leaks into long-term care practice, but these medications are often used in inpatient delirium prevention and treatment. Historically, antipsychotics were thought to be beneficial, and they're still used some in practice. But we know that we've studied it, and we actually have guidelines now that recommend against the routine use of antipsychotics to prevent ICU and hospital-related delirium. And so these medications should not be used in these conditions routinely. It's not inappropriate to ever use them, but routinely, the guidelines themselves would recommend against their use. Insomnia, insufficient evidence to support antipsychotic use in insomnia. You're using the sedative side effect to help promote sleep quality, but it's important to note that sedating a patient doesn't promote sleep quality. It may make them look like they're asleep. They may be asleep, but sleep quality is not equivalent. Sedation and sleep quality are not equivalents. And so we know that, in the general population, patients that drink alcohol before bed may be sedated by the alcohol, and they may actually sleep. But when you actually look at the sleep quality, it's very poor sleep quality. Same with benzodiazepines and sleep aids like Ambien. They promote sedation in the patient, but they do not promote sleep quality. And if you want to talk about somebody that's at risk for falls and at risk for behaviors, take away their sleep quality and you'll get that. And so we're actually cutting off our nose to spite our face in these situations because we're decreasing sleep quality in these patients, and sometimes chronically decreasing sleep quality in these patients, and then wondering why they're having behaviors the next day, or wondering why they're increased risk of falling, and they're more confused. And it's the same thing as taking sleep. When you take sleep quality away, you decrease quality of life acutely. There is some evidence for efficacy in the use of antipsychotics in acute agitation, but we should not continue them chronically. And sometimes acute agitation could be substance related. It could be situation related. And so we want to make sure that we're getting a formal evaluation and diagnosis of a psychosis-related condition if we're going to continue antipsychotic use for acute agitation. Next slide. So when we initiate antipsychotic therapy, ideally we want to make sure that they have an indication for use, either FDA-approved indication, or if we're using it off-label, that there's specific data for use in that patient population. We want to think about the patient-specific factors, so side effect profile. Are there any specific risks to the patient? Do they have a falls risk? Do they have other cardiovascular medications that could worsen their or increase their risk of arrhythmia? And in antipsychotic therapy, there's a lot of trial and error. Everyone is going to respond a little bit differently. There are now, I'm sure you all have heard of some of the genetic testing that can be done to help guide the use of antipsychotics and which antipsychotics a patient might respond to better. From my understanding and talking to psych practitioners, this is not something they often do on the very front end of practice. They often will start with a medication, and if they see failure, then they'll think about doing the genetic testing. I'm not saying that that's across the board, but that's generally what I've heard from practitioners. But there is an opportunity to try to be a little bit more intelligent or guided in the way that we start therapy. Next slide. So it's in long-term care patients, there is a risk of prolonged use of antipsychotics, and it's important to make sure that we're truly understanding the risks and making sure that the risks that we're actually imposing on the patient outweigh the benefits. And so we really are focused on reducing inappropriate use in the population because we're seeing poor outcomes in long-term care patients that are on antipsychotics. And so we've got to make sure we have appropriate diagnoses, and especially if we have orders for antipsychotics, and that provider is appropriate. They have the appropriate skill to appropriately diagnose a psychosis-related illness. And we would say, generally speaking, that off-label uses of antipsychotics are not appropriate in most circumstances. Next slide. So we want to differentiate patients with documented psychiatric conditions, ensure that there's correct documentation for use. We've talked to a lot of different facilities where the patient actually has a psychosis-related condition, but the documentation isn't there. Like, it just says schizoaffective condition, but it's not. So you want to first make sure that you're identifying patients that need to be on antipsychotics and that you're fine-tooth combing their chart and making sure that they have correct documentation for use. And then we want to determine if there's benefit and risk for the use of the antipsychotic, and make sure that we're reassessing that benefit and risk as the patient gets more medically complex and so forth. We want to think about reassessing their risk and benefits like we would other medications, anticoagulants and so forth. Assessment at transitions of care. This is probably the place where we see inappropriate antipsychotic use most creep into our facilities. Patients go to the hospital and the medication is added for the hospitalization. Whether that's inappropriate or not, it's often difficult to tell. But oftentimes you want to just, if the patient's coming back from an inpatient stay, we should make sure that we are addressing that. And most of the time, I'm not saying 100% of the time, but most of the time you don't have to do a GDR if the patient left your facility, went to the hospital, and then a week later came back on an antipsychotic. You can just stop that. You don't need to do a GDR for that. We also have seen issues where patients were sent to the hospital and should have been continued on their home or facility antipsychotic, and they weren't. And we've had complications from that as well. We also want to make sure that we're doing a polypharmacy assessment. Sometimes these medications cause side effects. A lot of times these medications cause side effects, especially in medically complex patients, and we got to make sure that we are triaging that and not adding medications to treat the side effects of the primary medication. And then we want to monitor for adverse drug effects and document them appropriately. Next slide. So there's a lot of risk factors in long-term care patients. These are often geriatrics patients. They often have comorbidities. They're at increased risk for polypharmacy. They have limitations at baseline to their independent activities of daily living. They have increased risk of falls and depression. And there's also a limitation in real-time multidisciplinary care. And so we've talked to a lot of facilities, and most of the time the pharmacist and the provider are leaving notes for each other, and they're not having a face-to-face interaction like you see in ambulatory care clinics, for example, where there's a pharmacist embedded in the service, and the pharmacist is going to the physician or provider and saying, hey, I think we should do these medication changes. A lot of times the pharmacist is coming to your facility, leaving a note, or remotely leaving a note, and the provider is reading it a couple of days later. And so there's not that face-to-face, and that limits the ability to optimize medication management, because there is just by nature a barrier between the providers there. There also are limited resources for care, and this could sometimes result in using antipsychotics inappropriately because somebody's having behaviors. You don't have enough staff to cover the patient. They need more hands-on care, and you call the provider, and the provider just wants to start an antipsychotic, and so that happens as well. And then the issues I mentioned with transitions of care. Next slide. So polypharmacy, this is using more medications than clinically indicated. It's typically when somebody's on 5 or more medications. It could be because they have multiple comorbidities. It could be because they have multiple providers or multiple pharmacies. It could occur at transitions of care where patients have a snowball effect, pun intended, with everybody in Tennessee mostly getting hit with snow yesterday. But there's this snowball effect of at each transition of care, you end up getting more and more medications, and you end up with a cascading of medication additions. And this can be a vicious cycle for the patient. It increases risk of drug interactions. It increases risk of adverse drug events. And it's incredibly costly. And so we can see that there's about 120,000 deaths annually from polypharmacy, and it can cost up to $50 billion to the medical system. Next slide. And so antipsychotic polypharmacy may be beneficial in some patient care scenarios, but we really need to focus on minimizing drug interactions and other medications. And are we treating the side effects of medications with more medications, especially with some of the medications we talked about at the beginning that have high side effect profiles? Are we seeing anxiety as a side effect of the antipsychotic and giving a benzo to treat it? So there's lots of different examples of that occurring. Next slide. We also have, like I mentioned, kind of continuing with the risks of antipsychotics in long-term care, falls risk because of the anticholinergic effects, the sedative effects. They can sometimes cause hypotension, poor sleep because of sedation and anticholinergic effects. The anticholinergic effects are drowsiness, dizziness, confusion. They're kind of in that figure there: dry mouth, constipation, blurry vision, dry eyes, urinary retention, those kinds of things. And there are some cardiovascular diseases that can be impacted by long-term care or long-term use of antipsychotics, like that metabolic syndrome, weight gain, and diabetes that I mentioned before. Next slide. The other thing that I think is important, especially in our patient population that tends to have a higher incidence of dementia, is that antipsychotics show an increased risk of mortality in patients that have dementia. And so if the patient has dementia, their risk of mortality is elevated when you put a patient on chronic antipsychotics. The association is dose related and medication related. So if you have somebody that has dementia and they're not on an antipsychotic, they're at lower risk of mortality than somebody that is on an antipsychotic with dementia. And then as you increase the doses, you see the risk increase. And so this figure here is a 10-year risk factor. And the highest risk is someone that is on dementia, has dementia, and is on antipsychotics. That red top line, the risk of death over 10 years is up to 80%, versus somebody with no dementia and no antipsychotics, where the risk is less than half of that. And so it's important to identify your dementia patients and really dig into why they're on an antipsychotic, because the risk of mortality is so high. Next slide. We also want to think about risks for dose optimization. We want to make sure that they're not having inadequate control, and so they could be hypoactive or have depression-related symptoms, and so they're not having positive symptoms or positive behaviors that make your staff say, "Oh, this person is having a psychosis-related issue." Sometimes inadequate control of psychosis-related symptoms are associated with hypoactivity or depression, and so it's important to look at both positive and negative symptoms alike. There's also a transition of care concern when you miss medications or have inaccurate dosing. And there are some other medications that can mask symptoms of psychosis-related conditions. And you should just pay closer attention to these patients, because we have two ditches. We have obviously inappropriate use of antipsychotics that we want to minimize, but those patients that have psychosis-related conditions, we want to make sure that they're adequately controlled and that we're not inadequately controlling them, because we have in our mind from these regulations, antipsychotics bad across the board. They're not bad in everybody. They're bad in some people, and we want to differentiate between them. Next slide. So there are a lot of different medication management strategies. Over the next 5 minutes or so, I just want to go over a few of them. Medication reconciliation is the first one. I think medication reconciliation and a quality, detailed, attention and focused medication reconciliation is one of the most important things that you can do for a patient. In my role as an educator of pharmacy students, I often emphasize that. My pharmacy students are often really gung-ho to, especially in the inpatient side, get to the bedside and help with, cardiac arrest and things like that. And, a lot of times I have to just say, hey, the most important thing that you can do is to make sure the patient's medication list is correct at every touch point that you can possibly do. We want to make considerations or have considerations and be thinking about medication appropriateness. As patients transition from inpatient to long-term care, as patients progress in their illnesses and in their disease states and their medical complexity, it's important to periodically ask whether a medication is appropriate or not. I know we've had conversations with a lot of different facilities that we've talked about, hey, is this medication really appropriate? Is it necessary for this patient to be on? Maybe it was 10 years ago when we started, but is it still appropriate? Looking for deprescribing opportunities, but also look for underprescribing opportunities and this idea of gradual dose reduction. We want to evaluate for drug interactions and dose appropriateness along the way, and that can help by having a good med reconciliation process. Next slide. So med reconciliation is the process of comparing a patient's medication orders to all the medications that the patient is taking. I have a list of questions that you should ask about each individual medication that get to not only an appropriate medication reconciliation, but also get to medication appropriateness and get to underprescribing and overprescribing. So the goal for a medication reconciliation is to get the most accurate list of medications the patient is taking, and to try to get, especially in the long-term care intake process, try to understand what the context of this is. Is this a medication that patient's been on for 20 years, or is it something that they've been on for 3 days? Because that makes a difference when you're trying to make appropriateness and overprescribing, underprescribing assessments. Next slide. So let's talk for the last couple minutes of this as we transition back to transition to closing out the session on gradual dose reduction strategies. I said at the beginning that gradual dose reduction strategies are really focused on information gathering. If you have gone through this process that we've talked about of identifying a patient that is appropriate or inappropriate, we'll say this is an inappropriate patient, they should not on paper be on antipsychotics, then we want to think about, well, what do we do next? So let's think about this idea of gradual dose reduction as a strategy to get more information about how this medication is impacting the patient. And so the gradual dose reduction strategy is a strategy for slowly but methodologically or methodically lowering medication so that you can optimize medication use. The definition of optimized medication use in some cases is getting the medication off of the patient altogether. Sometimes it's this patient can't be without this medication. And sometimes it's this patient needs this medication, but they can take a far lower dose. And that is helpful from an optimization perspective because we're decreasing dose, we're decreasing risk of side effects and risk of drug interactions. And if they have dementia, we have a decreased risk of mortality even. So those are the goals. As the goal really is optimization of medication use. And sometimes, like I said, it's getting rid of the drug or finding a dose that optimizes efficacy and minimizes side effects. It should be individualized to the patient and to the medication. And it's important to try to create an understanding that this is actually a positive thing for our patients, even if we're not able to take the medication off. And so we don't write GDR as a recommendation and say, oh, this is a big stigmatizing thing to talk about. And my providers hate when I request this. It's an opportunity for us to get more information about the patient, and that's helpful for optimizing their care. Next slide. There's been studies, lots of studies. I mentioned a few. There's lots of gradual dose reduction strategies. There's immediate versus gradual. There's some evidence to say that there's no major differences in outcomes, but there are some benefits to individualizing strategy based on the patient. Dose reductions are feasible and safe. This other study shows that, especially even in schizophrenia patients in late life, that dose reductions were feasible and safe, and there were improvements in illness severity, reduction in adverse events, and this is even when discontinuation is not the goal. So dose reductions can be beneficial to determine if the patient can be on a lower dose. As a side note, as patients age, they're going to typically need lower doses of medications because organ function changes, metabolism of drugs changes, distribution of body composition changes. And so oftentimes, even if they need to be on a medication, sometimes you can try to determine if a lower dose is more beneficial. Next slide. So we think that we would recommend gradual dose reduction as a conversation starter, not as a conversation ender. Gradual dose reduction strategies should be individualized to patients. They should focus on maintaining disease management, minimizing side effects, and reaching an attainable goal, whether that is discontinuation or a lower dose. They've been shown to be beneficial in the literature and in practice, and so it's important to try to reverse the stigma of gradual dose reduction and make them a positive thing for us to talk about and not a negative thing. Next slide. So you always want to ensure that you have a complete clinical picture of the patient's history and their medication list. Be careful with the information flow at transitions of care. This is a place where information can be lost. It's important to consider quality of life when you want to talk about a GDR. Some patients are going to respond well. Some patients are not going to respond well. And it's important to keep a close eye on the patient while you're doing these. You also want to document events so you can justify antipsychotic use, especially in those patients who might be on antipsychotics, don't have a specific indication, but maybe need to, and we just aren't able to do it because we're not doing good documentation. So we want to do lowest dose possible and monitor for side effects as much as we can. Next slide. So in summary, antipsychotic medications are common in practice. They have variable efficacy and safety considerations. Risk and benefit of starting, continuing, and discontinuing agents should be evaluated, especially in our patient populations. Off-label use is common in this particular class of medication, and while there are some benefits, in some settings, it's very situation specific, and it's important for you to understand the risk and benefits in your setting and your specific situation. We talked about gradual dose reduction. That is a strategy that shows benefit in patient care, and it should be implemented when it's deemed necessary. And we should always, always, always be focused on quality of life of the patient when we make informed decisions about goals of care for the patient. And that should be the main factor that we consider. With that, I'll turn it back over to the group to close out the last bit of this program.